Good afternoon, everybody. Welcome back. I'm excited to kick off our afternoon session. For those that don't know me, I'm Kiet Lam with Climb Healthcare Consulting. We're just very proud sponsors of this great chapter. And I do want to take a moment to thank all of our sponsors. Really, a lot of them are in the room here, so I encourage, clap. Let's clap for our sponsors. They were on screen. There's a lot of knowledge and subject matter expertise roaming the halls here, so I encourage you to engage with them, and I'm sure you'll pick up some good information and make some strong connections, so please do that. Let's see. I want to, I have the privilege of introducing Eric and Shonna. They come to us from Eclipse Insights. Oh, thank you. Well, there you go. You don't need me. You have AI. I've had the pleasure, and I know Shonna's going to give me a little grief for this, but I've had the pleasure of working with Shonna and knowing her for over 20 years. She brings deep subject matter expertise in charge capture and middle revenue integrity. She's seen it from the provider leadership side. And also now, having consulted for many health systems, just seeing it broadly. So really excited for you to share your knowledge, Shonna. Eric, I've met for the first time. Actually, my neck kind of hurts talking to you, Eric, up close. But aside from his dashing looks and height, he possesses 18 years of wonderful revenue cycle experience. They're both here really in a nutshell to share their knowledge of revenue cycle challenges and optimizing. How do we optimize our revenue cycle to eventually just ultimately increase net revenue? And that's really the name of the game. So with that, please help me welcome Shonna and Eric. They did promise me that they will just keep this to maybe 2 hours. So.
Thank you. No, so we do have 90 minutes. We beefed up our 55-minute presentation, so we should be good. But if you have questions, we definitely want this to be interactive, hear questions and ideas. Maybe you've solved for a problem that we're going to talk about and others in the room would like to hear about that. Very open to that with the 90-minute session. So we'll try to keep it engaging at least for 70 minutes and then see what happens. So so just to talk through what we'll go over. So why are we even talking about charge capture? Why is this a topic? Many of you in the room know, maybe all of you, maybe some of you are like, well, we'll find out. But just really what we see as the key challenges. We get the opportunity to go around the country and work with a lot of different organizations. So between Shonna's vast experiences, what we learn from our clients, just getting to take that all together and say, here's the best way that we've seen this done, and then apply that to other organizations. So kind of gathering those challenges and learnings into this presentation. We are going to talk about revenue integrity. That's often where many components of charge capture are owned, but not always, and every organization's revenue integrity department looks different. And then we'll talk through some very specific examples of how could you assess charge capture at your organization. If you say, hey, I wonder if we are missing something, some pretty specific strategies about how you could look at that. And then talk through some really specific examples as well. So hopefully something in here that you can take away, at least one or two things to say, I'm going to look at that when I get back and start pulling data and talking to some people. Because some of you might smell smoke in this area, or some of you might have amazing data on exactly what's happening already. And then definitely questions and discussions, but feel free again to raise your hand throughout, except Carla. She already threatened me in the beginning that she's going to cause trouble, so. All right. So just grounding what we're talking about in charge capture, because charge capture happens in different areas. And then if you meet the sponsors in the room, there are different approaches that kind of all get labeled as charge capture, but it might mean different things. So just clarifying what those things are. Obviously, very complex topic, and many of in the room are in revenue cycle or in revenue integrity. Do you actually own charge capture? Or do the departments, the people that are delivering the care that justify charging in the first place, do they actually own it? So I think we've all heard the term clinically driven revenue cycle. And with our modern EMRs, and maybe not everybody has a modern EMR, but a lot of systems now, we don't have to just give everything to the PFS office and say you have to do all of the charging. So we lay out the revenue continuum or revenue cycle, if you will, kind of from front, middle, back, just to kind of ground things from access through care delivery and post-care. So the couple of places that we really focus on, middle revenue cycle, so where the actual care is happening and how the care is being documented, how it's being captured for coding. Behind that, I would also say you have other things that you're purchasing that don't neatly fit on a rev cycle continuum, but what are we buying for supplies and how does that turn into something over here in the revenue cycle or pharmaceuticals? Then in our back end, we have edits, rules, exception reports, so charge capture, and of course, sad face, sometimes that's where charge entry is happening for some things as well. And then we'll talk about also kind of that look back analysis and just looking back at the whole picture. Anything I missed there? We good?
That's good.
All right, so over time, charge capture has evolved, partly with the technology that's available. But some of the major problems we see is who are the clear owners, right? We mentioned, and some folks agree, the areas that are doing the care, they own their charges. But we all know and appreciate what they really care about is treating their patients, right? I'm married to a nurse. I tried to ask her one time how charges dropped in her NICU, and she's like, I have no idea. Don't ask me that. I'm saving this baby. I'm like, that's a good point. So they don't care, right? Some of them, they're very focused on the patient, right? So this is not their number one priority. We don't want it to be. But somebody does have to be looking at it. And then, so who owns it? If you're the VP of revenue cycle, do you own charge capture? If you're the leader of revenue integrity, do you own it? You could probably influence it, and maybe you can have an accountability structure that rolls up to you where you have visibility into it, and then you can go out and say, but you probably need the highest level leadership at your organization to get them on board, right? Say our physicians, our nurses, our other clinical professionals have to at least understand what this is, and our department leaders have to know what their revenue is every day, or at least the day before, right? Or every week. So manual touch points, lots of room for error. Hopefully everybody's automating lots of things, but we all know if you've ever seen a nurse with like the supply stickers on their scrubs, or any of those falling off before they get scanned. Just the things that maybe your teams are manually entering. A lot of times coding ends up also doing some charge capture, or revenue integrity has people that are actually doing charge capture or coding or other things. Want to get away from manual, but I think we all know there's certain times when that's what happens. It's also very dependent on that clinical documentation quality, and I've heard physicians talk about this too. They are trained to document things in a way that helps other clinicians understand what they need to do if they see that patient next. They're not trained to document things so they show up correctly on a claim. So lots of training, lots of interpretation, and then, of course, system limitations. We've got lots of systems talking to each other. Sometimes they don't talk to each other, or we don't have the best way for them to talk to each other, but these are kind of the big buckets of breakdowns that we see. Anything else that you all are seeing? Just a lot, okay. Okay, so the value proposition, why are we talking about charge capture? Well, so you can likely see what your AR days are, although there's some organizations that aren't sure. But you could see your agings, write-offs. You can get to those types of metrics. But missing revenue, I mean, you could see things like late charges. once they post. Do you know how many charges that just never showed up? Very hard to know because you don't know what every little thing that's happening in the clinical areas. So this is that invisible thing that until you look and find it, you don't know that it's there. And so this is why we think it's worth looking at. And you know, it starts with the right infrastructure, whether that's a formal revenue integrity department. You know, a lot of, depending on the size of your organization, it might not make sense. But having the concept of revenue integrity, having an eye towards ongoing improvement of your charge capture, and then we talked a little bit about this, but having that organizational oversight, department buy-in and accountability, that they own revenue and they're going to understand what's happening with it. Value of this, reducing your compliance risk, improving your net revenue, and having accurate reporting. So we'll talk more about this too, but we hear a lot of times, well, that's not separately billable. Well, is it? Do you mean separately reimbursable or separately billable? Number one. Two, if you don't ever send the claim, do your payers actually know what's happening? When Medicare sets their rates because they think this is the cost of what it takes you to do this, if everybody is missing 1% of your charges, that's going to end up hurting everyone, right? And then also how it affects your cost report and your cost to charge ratio. So getting those charges accurate, even if you don't think they're going to separately reimburse. So the key drivers to address these challenges, in our opinion at least, improve documentation so that everything that is happening is actually getting captured in a way that you can use and support the charges. Overall charge methodology optimization, what can we automate? We got a fancy new system. Can the things that our people treating patients already have to document go ahead and drive those charges for us so that we don't have to later, they don't have to click into another screen and click little check boxes when they're trying to save the baby, right? And then aligning, when we talk about charge methodology, and Shonna will talk more about really all of these topics, but are our charges aligned to our resource use? Or did they get set 20 years ago and just increased 3% every year across the board, and now they don't really make sense? And you know, a patient that has more services or more resource use, consumption from your organization, does that end up being charged more? We'll talk about examples of that, like blood administration and things like that, that sometimes they just don't align to what you've actually done. Coding optimization, so having those audits, having the right tools. And then overall pricing reimbursing. So a little bit related to charge structures that report resource use is also just what is your strategic pricing strategy? Again, just flat increases. You're increasing gross revenue. Is it giving you any net lift? Could you target that better to say, our payers say CDM cap is 3%, 5%. Okay, fine. But the gross, you don't have to be equal, right, across every CPT code. We can achieve that gross number and have our net revenue be better. We might lower some prices. We might raise others because also some might be shoppable ones that impact the patient. The patient actually does pay more if we charge more. Let's leave that alone. Let's move, over here where when we raise the price, we actually get more from these contracts that actually help us. And then just reducing late charges and leakage. So, beyond just knowing what your revenue is in each department, is it timely? Do we have people that are going home and we don't either have the documentation or the charges that were supposed to be entered? Now it's 5 days later, we've already submitted the claim. Are we gonna write it off? Or are we gonna rebill it and go through all of that, and all the costs and delays associated with that? And then just, the longer things take, the more likely it is to be missed completely or again written off. So, anything else here? Oh, we talked about the invisible metric before. How much you're missing, it will vary at every organization. I don't think any organization is probably capturing 100% of everything that they ever should. What we have typically found that's available is somewhere between 0.5% of net revenue to 2%. Varies greatly on what type of contracts and payer mix you actually have. Is probably the biggest thing, and also your service mix and payer mix. So that's about the average. And also the maturity of your systems and the organization. You know, unfortunately, with some of the really old systems, we've seen much bigger numbers than this just because it's so difficult and cumbersome. If you have a really optimized Epic and all the right things working, it might be lower than this. Okay, this is where we talk about revenue integrity, and if any of you want to come up and just talk about this instead of me, you're welcome to. But the overall purpose, and again, some places it's a formal department, some places there's no concept of it yet. In other places, it's a concept that maybe lives in rev cycle, most likely, maybe somewhere else. But the purpose is that we have the right revenue, right delivery, right protocols, and the overall role, reduce leakage, degradation, and compliance risk. So a lot of that long quote at the top comes straight from NARI, which maybe some of you are also members there. But that's really kind of the HFMA of revenue integrity, but we like to talk about revenue integrity in HFMA too. Again, I have never seen two organizations that have the exact same scope for revenue integrity. Some of them, you're the CDM manager. Some of them, you're running all of the denials work for the whole organization and pretty much everything in between. But again, kind of benchmarking from NARI's view and our view of best practices, this is a group or an accountability structure that has overall oversight to the revenue. So we talked about just, do you at least have the visibility when a clinic is falling off or a department or a floor? Do you have visibility into that? And you're the people that go after that and say, something's happening with your revenue if they're not bringing it to you. We have clearly defined policies and procedures, the timeliness of charging, the documentation that supports what's in our room rate. Probably should have a policy on that, otherwise you get down the line and 10 years later people are like, oh, that's included in the room rate, so that's why we don't charge for it separately. Well, who said that? Somebody did that 10 years ago. There's nothing written that ever says at some places. So this might be the department that owns making sure those types of policies are in place. Generally own the CDM, or the concept of a CDM. Epic doesn't really have CDM, but KPIs, looking at those backlogs, denials. Again, some organizations, denials will live here, some just certain types of denials, or but charge timeliness, charge lags, late charge write-offs, charge reconciliation. So not necessarily doing the revenue reconciliation for everybody, but having oversight and visibility that it's happening, and being the ones that, if you don't have it yet, roll out. This is our new revenue reconciliation program. We have whole decks on that too, if they're helpful. Here's the why, here's who's gonna do what, and here's how you do it. And then the overall internal and external audits as well. So again, just pieces that may or may not be in your revenue integrity department. Okay, so best practices driven by this department or this concept. These intra-departmental meetings. So, your perioperative services leader. We probably should be meeting pretty often. Your leader of cardiology. Are we meeting to go through, one, what your revenue is? Hey, we started doing a new procedure. How many of you find out that they're going to do something? Or they just start doing it and then you find out? Yes. So that's fun, right? And it doesn't just affect charging, obviously. I'm sure then you got to support the coding and the billing. But making sure that you're ahead of those. And here's the CDM changes that happened this year. Here's all of our EAP records. that you have associated with you, and here's where your revenue actually came from for the last quarter. Is there anything we should clean up? Because it's the first thing that pops up when your docs start typing this word, but you don't ever actually use that. So can we clean that stuff up? And is anything missing? This is when we get to go do the departmental interviews, you learn a lot. What else are you doing that when I show you this revenue and usage, it's not there? Because it might be based on assumptions that you shouldn't be, or it's not separately billable or not separately reimbursable, but maybe there's something that should be there. And a lot of times, if you frame it such that, put it back to them as their productivity. That's a much easier conversation than saying we need your charges because the revenue cycle is greedy and we just want cash. This is about your productivity. If we don't capture the charges, you're doing all this work or your staff are doing this work, we can never justify more people. Well, maybe if you captured all of your charges, the picture would look a little bit different. CDM review and maintenance, we'll get more into that. Reporting and analysis, having, managing things with IT to make sure you know where all your issues are, being the drivers of certain goals and targets, just some examples. I'm checking time. I think we're doing okay. Okay. I'm trying to talk more than I usually did in this section just because of our additional time, so let me know if you want me to stop. Revenue reconciliation tracking. So again, there's multiple components when we talk about, okay, your department owns the revenue. What does that mean? Well, one of the things is they should definitely understand what's in their CDM. They should understand all of the services that are happening in their department. How are those charged for? Because they may not see it right away. But knowing that when we document this, it flows onto a claim. Or maybe it doesn't. Your nurses have to go into this other screen, unfortunately, this preference, and check the boxes. But then, knowing what the revenue is each day, each week, so that when something goes awry, they know about it right away. And you don't find out 3 months later, we were missing this one charge for the last 6 months. Now we have to do this massive rebill, and most revenue cycles don't have extra people sitting around that want to just do that. So then how do we know that they're looking at it? There are some fancy systems out there that can assist with that. Some places it's simple as an email. I can tell Warren that he's supposed to do it, and then he can tell me every day that he did it. There's systems, pretty simple systems that you can do that. But also, just this is a very simple example. This was not an Epic client, and so let's not let perfect or fancy be the enemy of good. Just get something in place. So that executive leadership can look at this and say, okay, why isn't radiology reviewing their charges? Oh, we have a new department director. Nobody ever told them that this was their job, and at their last place, they never looked at their revenue. So, and just making sure that this is happening. But having something, and you might have better tools, and some may not have any tools, but just getting something in place as far as the accountability and the tracking. Nobody likes their department or their name to be next to a red dot. This is very effective for many other things. So outcomes from having these types of things in place: better charge accuracy, better compliance, increased revenue, defensibility, being able to explain why things are the way they are, better efficiency, workflows, and just that better collaboration, right? When you may learn as a revenue cycle or as a finance department how to speak more like how your clinicians speak. They're going to learn more about maybe financial awareness and the key things that they need to do to keep that department open and keep your hospital afloat. All right, so now you're like, here, how much are we actually missing, or how do I start to figure out where there might be issues? So again, our going in assumption is that anywhere you have 0.5% to 2% that is missing. That's the financial side. But you can get results from this through EHR optimization, right? Finding where, again, this flow sheet row wasn't dropping a charge, but it could, instead of having to do this separate thing where we go to this other screen and check the box. And then the staff efficiency, again, kind of similar. When you optimize the EMR, you often also get staff efficiency, but you might identify a manual process that can't be solved by the EHR, but you can improve it. And then, better satisfaction because everybody's happier. And when they interact with patients, they're not in as bad a mood. Okay. Oh, that one, there's some stuff that's really invisible. All the different types of ways that things can be charged, right? And this is why it's not easy. It's not like when you talk to radiology, it's the same conversation as when you talk to peri-op. Manual in bulk charging, sad face. This is what we want to not do, but sometimes it's really what's happening with paper charge sheets and people somewhere else taking those, and lots of room for error, lots of room for things to be missed. Touch the wrong button. We have our kind of charge capture navigators or electronic pick lists. Might be documentation in the MAR. What does this one say on the slide?
Interface charges. And then the next one is the physician level of service calculators.
Yeah, so there's some white. They turned white in this.
They're on my
screen. They look
screen.
right up there.
Yeah.
So you have, your charge, your calculators. Again, we talked about flow sheets and just documentation, rule-based charging, and then fully automated. So some, very not recommended things on the left all the way over to the right where we want to be, but lots of different ways that this is happening. So then what are the different things we need to look at? So we have the technology, the rules engine. Epic has Revenue Guardian. There are some business partners in this room that have tools to capture some of this. And those can be very good to have, and we'll let them explain those to you. But just having that reporting, your charge master and item master review, so we get new codes all the time. Certainly need to at least be looking at it every year, but your NDCs and things, making sure that our dictionaries are correct and that things are mapping to the right place. We often, when we look at these things, we find that, hey, you've got chargeable things that somehow got mapped to the non-chargeable shell code, so you're just missing this every time. You find that by saying, look, you bought 10,000 of these, you aren't charging for any of them, but there are so many complex interfaces or other things, or how do they get entered into the system in the first place? If I'm a medical device rep and I bring something in out of my trunk today for your surgery today, what happens with that? Do you have a good process where that is getting captured? Or do you have a paper invoice that somebody may or may not be able to find? And then your fee schedule review. So, making sure it is alarming how many times you can look through somebody's CDM and find out that they're charging less than Medicare rate, they're charging less than one of their contracted fee schedules, and then guess what the contract says? Lesser of. So you're not even getting as much as they're telling you you deserve. And then people in process, and this is really important to us. So I mentioned talking to the departments, finding out what are they doing that they maybe are wondering if it should be charged. They don't see it in their stats or whatever they're looking at, but they're doing it. Their people are doing it. And then getting into the process, what is the workflow? So what does your physician do to capture this? What does your rad tech do? Let's walk through that workflow, see if we can improve anything. That also sometimes identifies things that they didn't even know to think about that they might be missing when you walk through those things, and you can find out what they're missing. But just really rolling all of that up, what's happening in the system. I know it's getting cliche now, people, process, technology, but those are really the components that are driving all of this revenue. So what are the people doing? What's their workflow? What's this technology that's supporting it? And what's missing from that or needs to be fixed within that? mentioned earlier, your reimbursement landscape, we think that everything should be charged. Like you can find references in CMS. If you do it, charge it, right? But the real impact of this work, beyond being more accurate, is your reimbursement landscape is going to drive the biggest thing. So if you're already on prospective payment, some of these things may not matter. However, do we have anything that hits outlier status? And now every time we hit an outlier, having those charges would have been really nice. Or certain carve-outs for implants or certain high dollar things. PBS versus critical access. It's also have heard very interesting assumptions about, well, we're critical access, so this doesn't matter because, cost base and whatever percent, 30%, 40% is still commercial. And I think the best contracts that we've ever seen are still sitting with critical access because of the people that you all serve and how you need to stay supported, and those health plans need you to be there to take care of their members. So, making sure that regardless of the reimbursement structure, there's probably some type of opportunity, but when you're really looking at what is the net impact of any of this work, definitely have to take this into account, and it might be different by payer, product, inpatient, outpatient, all this. Okay.
Question, Eric.
Yeah.
Can you go back last time? So on the topic of percentage charges, I'm sure you've seen this, and I'm sure a lot of us in this room are experiencing it, but the payers are obviously, paying a lot of attention to contracts and rates that are based on percentage charges. So what we're seeing our clients struggle a lot with are these bundling charge denials, and it's just really difficult to overturn on an account level basis. So thinking about different strategies to either recover them from a sort of broader perspective, or perhaps how do we change our charging strategy to maybe mitigate some of it, whether it is, hey, I should be bundling some of these, ancillary charges into something broader like a procedural or a room and board charge or anything like that. Do you have thoughts on that?
So I think there's a couple of different ways you can look at that, right? First of all, is the denial really stopping anything from moving forward, right? So are you still receiving payment for the other services? And the denial is really informational, in which case you're reporting the information appropriately, and it's a contractual at the end of the day, basically. So that's like one thing, right? And I think oftentimes organizations get caught up in the fact that it's a denial received, but is it a denial received that really needs to have action taken? So that's one component. We do and have seen payers who have percentage charge say, well, I'm not going to pay for this, I'm not going to pay for this, I'm not going to pay for this. So you are missing out on things. I would say across the board, there is, and I do have a slide later on, there is regulation from CMS that you should charge for all of your services, right? So I think a component of that is a good coordination with your managed care department, because there needs to be contractual language to safeguard you. Your negotiations that happen with your payers are based on your historical charges. And you agreed to a percentage charge because you understood the impact of that. Then they start nickel and diming you, and that was not the intent of the contract. So I think it's not the quickest resolution to the problem, and it can take a long time, but I do think the root of it is that there is intent, and there needs to be a good coordination and feedback loop with your managed care department. I don't know if that answers your question.
Yeah, I would just add, and this is what you're doing, but where does our contract state that you can do this? Now, unfortunately, they're probably going to point to the little line that says policies, and then it's over in this policy. I think our view is, if you have a true percentage charge contract, that's still against the spirit of that. Now, whether you're going to be successful winning that, I don't know. But if also 60% of your payer mix is doing that, and it's creating this issue because you have the denials, is there a way to just automate resolving the denial and still picking up that revenue for the payers that aren't doing that? Or do you want to change? Because if you change your whole charge structure, I just think very often, unfortunately, we see, well, Medicare does this, So we're going to set up our whole charge methodology around Medicare. Well, Blue Cross is your biggest payer. But even then, if Blue Cross does this, should you set up your whole charge methodology around Blue Cross? Or do you have 10% of things that are still going to have a net revenue pickup? And so I think just putting it on balance. Like, if you were never going to get the money, fine, then let's not work it. Maybe let's not even treat it as the same type of denial. Is there a managed care thing that we can address? But if we're going to think about changing the charge methodology because of them denying us, I think you need to think really hard about what the whole picture is.
I think, too, there's a lot of complexity when you start bundling things. So there's a reason why in publication 100.4, Medicare says, charge for everything that you do. That's how they rate set, and they're historically 2 years behind the curve. And once you start removing charges, but over the years, your costs for those things change, but you don't have a direct line of sight of what component is changing because you've bundled things together. How are you going to effectively set the charge on that going forward so that that historical information can be used in the future to then increase your payment rates, which is what you deserve because it's costing you more to provide that service? So by saving time now and not having to work denials because you bundled things, you're shooting yourself in the foot going forward. My personal opinion, but.
I've also recently had some conversations with like directors of managed care and payer contracting at some organizations because one said, because of our great percent of charge contracts, they're doing all these things that you're describing, and now it's creating so much administrative burden, we just want to go to this new set rate methodology. So then I talked to another director of payer contracting. I'm like, I don't think they should do that, but what other advice? They said absolutely shouldn't do that because you go to the set rate methodology and they do the same thing. They just played, the game just looks a little bit different. That was their opinion at least. So I don't think that there's one great solution. I think you're going to get denials no matter what you do. But I just thought those were interesting perspectives, one that wanted to get away from them. And then I think I talked to 2 or 3 others that were like, absolutely, if you have percent of charge, do not let that go. And if they want to come to the table, if you don't have to, don't. All right, so again, review areas. I'm going to pass off to Shonna in just a second to kind of get into more details, but just that overall data analysis. What does our revenue and usage look like? What does it look like by department? What does it look like over time? Is it going in the right direction? Do we have days that don't look right? What's actually on our claims? There might be soft-coded things that you can't see in your Epic revenue and usage that are on your 837s. Or things that get stripped off. Your orders, your purchasing data, so I mentioned purchasing data. If we're buying a lot of something, and we never see it over here in the revenue, something is broken in those links that we have. And this relates to the dictionary review. So again, just looking at those dictionaries, sometimes we just have to ourselves or have someone else sample accounts. Chart to charge, right? We have these things in the chart. Did the charges post on the account? Did they show up on the claim? And tying those things out, we'll often find issues somewhere along the line there. Again, looking at the workflows we talked pretty in detail about, and just meeting with those departments, seeing what they do understand about their revenue, what they don't, what's new, what's coming down the pipe with new technology, new services. All right, so all of that, now that once you do that, you'll be good. Service capture assured, improved net revenue. So I'm going to hand off, I believe. All right, one more thing. So just one way to bucket. A lot of times, once you do all that review, the majority of our issues, if not all, will bucket into one of these 3 things. Do we have the right charge methodology? And we'll talk about really specific examples of that. Is our technology supporting the workflow correctly? Do we have the best technology that we should, given maybe the ROI on that technology or the investment we have to make in updating the technology we have? And then, or is it education? The RTs just didn't know they were supposed to do this. So those are kind of the 3 main buckets that you'll generally find, and it might be a helpful framework as you go through the issues and say, Is this a system? Because if you just give all of your findings to one group, they're going to look at it differently. If you just give it to the training team, they may not see it the same way as the list you give to IT. And neither one may be able to solve all of them. Right? That's what Andrea's for. She has to come in and do that. All right. I will keep this mic because you have that. In case there's questions, I'll keep my eyes out. Carl, if you do have a question now, I will entertain it at this time. Okay.
All right. Thanks, Eric. All right. Common areas of opportunity. This is going to look different for everybody. This is just general areas doing this over the last 20 years. There's different components of the organization that are going to lead to this being an opportunity, whether that's your service mix, your payer mix, your contracts, obviously. But these are common areas. So, for example, perioperative services. Do you have a single level charge that has a time component? That's great. A time component is great. It kind of helps you account for the resources and time of the staff in the room and the overhead costs, et cetera. But does that really break down and help you account for the acuity of the services that are happening in your OR? So there's a few different ways to look at it. We often find opportunity here. It ranges from organizations that have every procedure they could possibly schedule in the OR built out manually with a price associated with it, to organizations that have, like what I just mentioned, a single level charge that's not really accounting for patient acuity, to some of those organizations that I would say are doing best practice, which would be having different levels that correlate to the different services that you're providing in that case, that account for all of your non-billable things. So setup, tear down, number of staff, instruments, trays, non-billable supplies, specialized training, specialized equipment. A tonsillectomy should not be charged at the same rate as a total knee replacement. It's just common sense. There's going to be a lot more resources that are used that your organization is paying for. You should be reflected in the charges. Lots of other examples. Neurology. People might not think to look for opportunity in neurology, but this is a space where, and I have some additional slides later in the deck, new technology emerges a lot in this space, right? So some of you may have heard of NTAP, new technology add-on payments, maybe not. This might be a space where, as Eric mentioned before, 3 months down the road, you find out somebody was using this really great, cool new technology, and nobody shared that was happening. And you could have been receiving thousands and thousands of dollars of additional reimbursement had you known about it and been able to code and charge appropriately for that service. So again, with what Eric was talking about, having those regular meetings, at least on a cadence with those departments to be able to identify those things really helps, because we find opportunity in those areas a lot. I won't drain all of these different things, but as you can imagine, there's lots of different opportunities depending on the size and scope of the services provided by each organization. Any questions on that one? Okay. So just to drill down into a few more common opportunities. So as Eric had gone over the slide of those different buckets, so you have charge methodology. I just talked a little bit about the operating room. Oftentimes it's, so it's lumped in, peri-op includes anesthesia. There's a lot of times that organizations don't even think they can charge separately for anesthesia. They think it's a professional charge. So we find the gamut of that, just depends on the organization. So knowing what services are out there that being provided and what as a facility you can charge for is very important. I would say another example related to anesthesia, I don't want to date myself here, but so back in 2017, I don't know if you guys remember when you used to actually use a paper CPT book and you'd flip through and you'd get to a CPT code and it'd have a bullseye next to it. What did that bullseye indicate? It indicated that moderate sedation was included as part of the procedure. It wasn't a separately billable thing. In 2017, AMA said, well, we're going to scrap that because if another provider provides moderate sedation, and a provider being even a CRNA, the services provided by the facility, they can bill for it. Oftentimes, organizations didn't know that happened, and up until even a year ago, we found organizations that weren't billing for moderate sedation because they assumed it was included in the procedures. So there's different things that if you have a team of people that are keeping abreast of changes and meeting with the departments, you can identify opportunities. And I would lump those into methodology because it's like a decision of how you're charging for your services. And not to belabor the point that Eric was making, but just organizational decisions like, hey, Blue Cross and Medicare don't pay for venipuncture. So as an organization, we're just going to stop charging for it. That happens a lot. And sometimes, the workload that is reduced by making those decisions is helpful at the time, but I think it's shooting yourself in the foot in the long run. Yeah.
Hi, this is Andrea from OHSU. That brings up a really good point because I also feel like the cost report issue, right? If you have a payer mix that's heavy Medicare, what would be some opportunities that you've seen where you would maybe have ROI in charging for things that are manual or require a little bit more FTE or workflow?
Yeah, that's a good question. So, and I think that's one of those that sometimes maybe feels a little intangible at the beginning because capturing it, to your point, requires resources. Nobody wants an extra step of doing something. So that's where automation would be great, not always possible. But the cost report and the implications of not reporting that information appropriately, so it has to align with your charges. You get your cost to charge ratio. People aren't necessarily paid on your CCR, but it is a component of every calculation. It is a piece of every calculation of your Medicare reimbursement. So, there's huge formulas for how they calculate things, and cost to charge ratio is a component of it. So if you stop charging for services and you're maybe not aligning those expenses on your cost report effectively to the right revenue, the cost center, then they're not able to determine those metrics for what payment should be and what that ratio is and how to apply it to your overall services. So sometimes it's a long game, but it's important to start now because as I mentioned before, Medicare's at least 2 years in arrears on making those calculations. If you just think about what's going on in the world today, right? Supply prices are increasing, different things. But if you're saying like, hey, I'm not gonna charge for these things because it takes somebody taking time out of their day to enter these charges or do this, I'm just gonna stop charging for them. In a couple years from now, when those prices have even gotten higher and your organization is paying more for them and you haven't been reporting it, your cost to provide that care has gone up, but you're not gonna get paid for it. So, yeah. Charge reconciliation and maintenance. So important and oftentimes overlooked. And it oftentimes falls to the back end to do this. But who knows best about the care that's being provided? The clinicians providing that care. A lot of times we'll go to organizations and we'll have those interviews with clinical areas and we'll ask them, how is this, what is the charge for this? Do you charge for this? I don't know, that happens on the back end. So without knowing, they don't know the implication of not doing the documentation that supports it or that drives it. And so it's super important that they're involved in that process. You will receive pushback if it's new to your organization. But in the long run, if you make actionable reporting to help with reconciliation, they will thank you for it. Because as Eric mentioned before, ties to productivity, ties to supporting services, getting that new technology that they can provide to their patients, getting that super expensive cancer drug that they have patients that direly need but are going to go somewhere else because as an organization you can't afford to front the cost of that. So super important. And then just documentation, the old adage, if it wasn't documented, it didn't happen. So very true. So that component of working with the clinical areas and making sure that they're documenting everything that they're doing. They might not know that a component of what they're doing is important until you align what they're doing with charges that can represent their services and show them where and how they can do that. And hopefully it's an efficient way of something that they're already documenting and you can leverage the system. So, and then I would just say oftentimes there's opportunities after system upgrades or updates, and logic that you created in your system as a workaround because you couldn't get automation before gets broken because it's not standard, it's not foundation. And so really looking at revenue over time and trending and your daily, weekly reconciliation will help identify those things quicker if you have a reconciliation process in place than if you don't. So, all right. Improvement opportunities. So as I was kind of just alluding to, there's a lot of charge capture rules and system logic that you can leverage. Oftentimes, this is where we find the system might just be, so for those of you on Epic, the charge router maybe is deleting a charge because somebody thought that was a good decision at some point. Nobody knows that it's happening. The charge isn't there, like Eric mentioned before. If it's not there, you don't necessarily know that it's missing if you aren't reviewing your logic and things that are happening. So just having a process for annual review of all of those different components within the charge capture workflow really, really makes a big difference. And you can find black holes that you didn't know existed by having that be a component of what you do. The dictionaries are super important, especially for organizations that are leveraging like shell code logic, where you're relying on a department that maybe isn't often involved in billing and revenue to understand the importance of the accuracy of the items that are interfacing over to the charges. So as an example with pharmacy, maybe they are using a default NDC 100% of the time. You don't have BCMA, barcode scanning. For ease of what's going on, you set a default. You no longer purchase that NDC, but a different NDC, and that different NDC costs you 3 times more. But people didn't know that your default was set to the other one, nor did it get reviewed or updated. And now an organization is giving away drugs for free almost because you're paying more for it than you're charging. There's different opportunities, but without having that review of what's interfacing in, how it's doing it, that you won't know that that problem exists, right? Also with like multipliers, something changes, they're dispensing a different drug, they maybe even fat finger a number and wouldn't be necessarily super important from any of your percentage charge because that charge is still going to go out with the right amount. But you have a fee schedule payer. Now they're only getting 1 unit instead of 10. Now you've just significantly decreased your revenue. So super important items. Nursing workflows and physician documentation. There's a lot of opportunity and a lot of correlation between what the physicians do and what as a facility you can charge for. Are you looking at that correlation? Does it make sense? Are you looking at the physician charges and your hospital charges? And do they jive? They're not always going to be 100%. And based on your organizational policies and procedures, they might not align, and that's appropriate. But when you have a specific procedure that has both a technical and professional component, are you capturing it every time that happens? So just really important that if somebody's documenting it and they were able to capture it, it should be 2 sides of the coin. Another opportunity that we often work with organizations on, there's like a lot of misconceptions about how you can charge for your trauma services. So a lot of times there's a misinterpretation of the regulations around trauma services. There's specific coding for trauma services. And yes, that's how it should be represented on a claim when it goes out the door. But there is no regulation for any organization that tells you you can't charge for services you provide. It's the way in which you represent that information on the claim that tells the payer the true story of what happened and if it's a reimbursable service from that payer. So again, just aligning to document what you do, charge for what you document, get paid for what you do. So, other areas we find opportunity is when you have a service that you provide 80 or 90% of the time in a specific department, but you have an outlier. So like maybe my CRNAs run up to L&D or go over to pain management and provide anesthesia. But when they log into that department to do their documentation, things look different. Charges aren't set up to trigger automatically. Whatever it is, they don't have a charge capture screen built out because nobody thought, hey, we got to charge for this service when they log into this department or come over here and provide this service. So it's happening 100% of the time when they document in one area, but when they go to another area, it's a different workflow. And that workflow hasn't been evaluated for the appropriate charging. So it's super important to understand, again, I'm beating a dead horse here, but what are the services that are being provided? Where are they being provided? How are they being captured? And then just proactive audits. So it's hard to fit one more thing in everybody's day, but you never know what you're going to uncover when you're just poking around. Often can of worms, right? I'm looking at something for one reason and I might identify something else. That's where we find a lot of opportunities, honestly. Well, I expect to see this device with this procedure. Wait a second, why isn't that drug charged here? Like, you know, you go down a rabbit hole, but what did it do? It identified that there's something missing, and then you can look into what is the workflow around this, why did that get missed? So super important to have proactive audits, not just when you know there's a problem, but when you're looking for stuff. So examples of maybe an overall review, right? So you could have a great charge reconciliation process. It's extremely robust. You have great CDM and dictionary maintenance. Things are looking good. You actually do collaborate and get feedback loop with your departments. However, to Eric's point earlier, you don't know what you don't know. So you may have a workflow that only works when you have certain people in the room to do it. And maybe Sally went on vacation and it just so happened nobody looked at the schedule in advance. And if you have a great process and you have people that are counter-trained to support each other, somebody, I don't know who, let them both be off at the same time. And now you've got 2 weeks of charges just piling up because nobody's there to enter them because it happens to be a manual process. So there's lots of opportunities where you maybe don't think that there's opportunities. And it all comes down to people, process, technology, what's working, what's not. You know, finding times where charges maybe are being captured appropriately. If you have a multi-facility organization, captured one way at one facility, different way at a different facility, are you doing the review to compare the facilities against each other to make sure that it makes sense? Because then you might find some opportunities there as well. And then of course your high dollar areas, right? So cancer center, cardiology, those places often have a more complex situation that requires review, and you'll find opportunities. It's important to know, though, of all the opportunities that you find, how do I prioritize this, right? Nobody has an extra minute in their day to start a new project. But while you're figuring out, hey, I've identified there's an issue, and I know it's going to be a longer run issue, but it's bigger dollars, can I also find some quick wins and do that at the same time so that I can get that revenue that's the low-hanging fruit? But I do need to pull together the right team to really fix the problem that helped me to identify that there's an opportunity in a specific area.
And
I would
Shonna,
say
they really can't see the bubbles out here, just letting you know. The slides are in the app, so you can get them there. They'll look better.
Okay.
Or we can send them to you if your app doesn't work.
Yeah. Well, I'll move on. But just basically, you know, if you have a work plan, you have an idea of what you're going to tackle, then those bigger projects can feel a little bit more attainable while you're also able to capture some of the quick wins. So I'm going to get into some very specific details here. So I apologize to anybody who doesn't love charge capture. All right. So here's an example of what I was kind of just referencing. You have 2 facilities, just as an example. But for whatever reason, those 2 facilities have charges that are set up differently. That could have been from a merger, acquisition, 2 separate systems, 2 instances of the same system, but they're different. We've seen it all. So that's why it's helpful to really compare your different facilities and look at it not just from, hey, this organization has X dollars in revenue month over month, and that's good, and so does this one. Okay, everything looks good. But is there a way in which you can simplify and standardize the build so that you move some of the burden off of that CDM maintenance that you have annually, right? Who likes going out there, and the annual update always comes at the greatest time of the year. Thank you, CMS. It's, or AMA even. Right before the holidays, right? Everybody's stressed and busy, and you got all these charges to look at to make sure that were they added, were they removed, were they revised? And when you have different charges that are set up for the same thing but applied differently throughout your CDM, it just makes that burden so much harder. So just looking at the different ways in which you charge things across your facilities. Going back to that really quick, sorry. Does anybody have that situation now where you have multiple facilities that charge the same thing different ways? Does it make your life a nightmare sometimes? Yes. All right. All right, trending data. Now here's just a little example, smoking cessation, right? It's a charge for counseling. It is billable both on the professional and the technical side. Here's just an example of facilities. So it was an organization that actually had 3 facilities. The 3rd facility wasn't charging for it at all. Sorry, you guys. I'm click happy. Facility 1 charges for it on the outpatient side, and facility 2, a few times, charged for it on the inpatient side. There's just an opportunity when you're looking at your revenue and usage to identify what is the rhyme or reason behind what I'm seeing in the data? Like, do I need to go out and provide education to some of those outpatient departments at facility 2? Because they're probably providing the service if they're doing it so much at facility 1. But I need to ask the questions. Are they actually providing the service? Is it because they're not documenting it, and that's why? Is it tied up in a random free text component of the note, and nobody thought to capture the charge for it? So different ways in which you can look at the data to help you really identify where there might be opportunities for your organization. Any questions on this? All right. Told you I'd get to NTAP. It's quite complicated. Hopefully you can, very small information on this slide here. But basically, new technology, CMS recognizes, as I mentioned a few times, they're in arrears on calculating payments. So you have a procedure that you're doing, and now you bring in new technology. The payment for that procedure is based off of a couple years ago. It doesn't take into consideration the new technology. So CMS has said, okay, well, we're going to rectify that situation. You coded appropriately. We're going to pay you for it. However, it's heavily reliant on coding, and coding knowing that they should be looking for it. So CMS publishes the file 8, but what's file 8? It's not a complete story. So it tells you, it has a tab for new technology that's new this year. New technology payments are generally good for 3 years. Sometimes they extend them. They have a tab for continued, and then they have a tab for discontinued. What they don't have on there is a trigger point for anybody to say, in my system, how do I capture these accounts, right? So just highlighted one example here, right? There's 2 drugs. The 2 drugs are probably used separately on many of your patients. When you combine them on a single patient with a very specific PCS code, you'll get additional payment. Without knowing that, the coders, who most likely don't look at your drug charges, because that's not part of my coding process, how would they be capturing this? How would they know? Because it's an education component. So you need to have a process in which at least annually you're meeting with the coding team and talking through the new technology, meeting with the clinical areas, asking them if they're going to be doing any of these new technology services so you know what to look out for, and sharing that information so that you can receive that extra payment that you're due, because these services are expensive, so you should get paid for them. Anybody doing any new technology at their organization? Do you find out about it before or after the fact?
We're excited if we find out before.
That's a good answer. It's a positive spin. I like it. All right, here's another one. So this one is now a discontinued payment, but it's still important to capture. Gonna beat the dead horse again, because you want the information relayed to CMS appropriately so that they continue to set the payment rates for those services. So you may have gotten additional payment for a short amount of time if you billed it correctly. You want to make sure that that continues into the future. This one specifically, so shockwave catheters. If you didn't have a good discussion with your materials management department when you were advising them or hearing from them what code they thought should be connected to the charge information that's being interfaced in through and connecting to your CDM, they may have applied 1725 to all of the shockwave catheters. The C1761 was important for your coronary shockwave catheters. They may have said they don't know how to distinguish the difference because nobody told them. The C2s, those are the ones that need the 1761. I've seen it where organizations slap the 1761 on everything, not appropriate. I've seen it where they didn't put it on anything, also not appropriate. At the end of the day, you're leaving revenue on the table. So just important, older example, but still relevant. Here's another one, a GORE excluder. This one's fun because it takes a combination of PCS codes to trigger for your NTAP payment. However, oftentimes, coders are looking at it, and because it's new technology, might not be understanding that it requires both of those PCS codes. You're looking at almost $30,000 that you're leaving on the table if you didn't capture that. So just super important to have that education out there, and just making sure that the coders understand those new technologies and how to find them, which is probably a coordinated effort with some sort of reporting to get them that information. Here's an example of pricing reviews. So, occupational therapy. Oop, gosh, every time I hit my, sorry guys. Evaluations. So, CMS actually got smart a couple of years ago, and they knew that people were providing evaluations at different time increments, right? So they actually created new codes that are specific to these types of evaluations and how you break them up. You would maybe not be amazed, but I'm amazed continually about how often organizations still price them all the same. You're providing a service. Does it really make sense for a facility to charge the same for a 30-minute service as it does for a 60-minute service? Your resources are different. So you got to look at what you're doing, the services that you're providing. Do your charges make sense? There's a lot of strategic pricing, maybe not doing strategic pricing where things are just getting updated. The important component of revenue integrity and or your CDM person who's involved in that pricing process, whether it's a vendor or internal, understanding the services that are being provided. Maybe most of the area in which you get additional reimbursement in your therapy services is based off of revenue code. So nobody really cared about the fact that these CPTs had the same or a different price. It got overlooked because you didn't have the subject matter expert weighing why that's relevant or important. So another component of the pricing to just consider is looking at addendum B, looking at your pass-through payments, any separately payable services. Is your price, as Eric mentioned before, set so that if you were to bill out that service on a claim by itself, because that's what happened, the patient came in for the one thing and the claim went out the door, did you actually charge less than anybody was willing to pay you? And therefore, you're leaving money on the table. So there's a lot of codes out there, but obviously you want to focus on the ones that are going to get separate payment and make sure that you've set the prices appropriately. Another thing to look at is not only levels for your organization and how you're applying the methodology behind how you assign levels, but looking at it and slicing and dicing it a few different ways. So you may think like, hey, I'm going to pick on neurology again just for fun. So neurology department, they have a fairly decent bell curve, but when you break it out by the different providers, Dr. Smith always charges a level 2. Just a little more risk adverse than Dr. Eric. So, just slicing and dicing the data a little bit. The first pass at looking at your revenue is not always going to show you the full picture. I would also say, in line with E&M levels and talking a little bit about what we mentioned earlier about, hey, well, somebody doesn't pay for this, or this payer doesn't want me to bill for this way. You wouldn't believe me if I told you how many times organizations, and if it's your organization, well, here's a hint. So, how many times organizations, when CMS came out with the G0463 for their E&M levels, decided they're only going to pay us one rate. Let's just simplify everybody's lives and bill one rate. Okay, well, that's one method. However, you are leaving revenue on the table. You're also leaving your ability to report on your resource consumption, the work that it takes to see these patients get through their visits, the staff that are involved in this process, not just the physician, but AMAs and nurses and all the different, potentially supplies and things that are not separately billable during those visits. So looking at it from a few different ways, understanding the methodology behind how your charges are captured and capturing them consistently. All right, line item reviews. This one, again, I would say probably also falls in your pricing review, something to look out for. When prices are set by individuals that don't understand the services being provided, maybe it makes sense to them in their head, first order, second order, third order, logically, sure, let's have that in a decreasing amount of money, because third order is probably just not as hard to do. That has nothing to do with what this code is saying. It's a hierarchy. It's coding related. Nothing to do with the service, like the resources consumed by providing that service. It's actually the same amount of effort to go to the third as it is to do a first order. It's just the way in which the CPTs are set up, meant for capturing by coding, not how much it costs or how long it takes to do it. So just different ways of underlining the importance of meeting with the clinical areas, not only for annual coding updates, but for the pricing review, because they know more about the services they're providing than any of us would. I think Eric touched on this one, so I won't belabor it, but you have purchasing files. You have things that you're buying that maybe you're not charging for. A lot of times there's a policy. A lot of times there isn't. Do you have a threshold? What is that threshold? What happens if a supply falls under your threshold but has a HCPCS? CMS decided the device to procedure list was too much to publish anymore, but they still use it in their logic. They just don't want to hand it over. So it's important to know what's out there, what you're charging for, how can that have a trickle-down impact. So if I'm not charging for something, but I'm paying for it, the cost of my service is not reflected accurately. And in a different example than the one that's on the screen, I may actually be creating some claim edits and back-end work because I've decided I don't think that that's billable, or it falls below a threshold. And that's a decision that's made, but maybe it needs to be revisited. The line item review, again, this has a few different implications, but interfaced information or hard-coded information, all payers look at claims differently. There's a lot of fields on a claim. Some payers have carve-outs that are revenue code based. Some payers have the specific HCPCS that are carved out. I've seen very intricate contracts that are like, well, if you charge this cardiology service under this revenue code, you'll only get paid if you also have this. It's crazy, but if you're not applying the right revenue codes and HCPCS to your charges, you're potentially leaving revenue on the table. So, I did mention earlier that publication, I have it here on the screen for you guys, 104, charge for the services, whether or not the service is separately payable. So, you may not receive separate payment. CMS wants to know about it. It's all part of the big calculation. the magical reimbursement model that is so hard to decipher. But it's so super important. You also want to make sure that you're charging consistently. So I'm not going to charge Blue Cross for this item because Blue Cross pays for it and not charge Medicare. I want to charge everybody the same. So if I decide that Blue Cross is not paying for something, I don't just stop charging Blue Cross. I stop charging everybody if that's a decision that I make. So a lot of implications around how you make decisions, but so often I think that the biggest discrepancy or issue at the root cause of this is separately reimbursable versus separately billable. Two separate things. So you can bill for a lot of things. There are very few statutorily excluded exceptions where you can't bill for something. You are supposed to bill for everything you do. It's how it all gets calculated. So just some questions that you can ask yourself. I think Eric touched on a few of these, but what's included in the procedure charges? We'll be talking to an organization about their peri-op services and be like, well, that's included in our charge. Well, do you know what your charge is? Well, no, that's figured out on the back end. Well, then how do you know that the charge includes that? When was the last time that was reviewed? It's part of the room and board. Well, what's in your room and board? Well, I don't know. I don't know. We don't have a policy on that. So, a lot of different things that can go wrong when you assume that something is set up a certain way, and information does get passed down from person to person. But sometimes you just have to question that and dig a little deeper. And that's cost-based analysis are really important. So if you did make a decision as an organization to roll things in to a procedure, to a room and board rate, you need to review it because costs go up, but did your charge go up accordingly? Also, if you've rolled services in, you want to charge patients based on the services they were provided. So if you've decided as an organization, I'm going to roll this up because of whatever reason, is it fair to patient A that didn't receive that service that you're billing them more now because patient B received that service, but I don't want to bill people separately for it? So just things to think about. Is it fair? And then just understanding the impact of those decisions. Did you thoroughly look through all of the contracts to understand the volume and dollars associated with making that decision? Any questions here? Any organizations that hear things like this, see things like this happening? All right. All right, so lots of tools and logic. This can be great. This can also be a downfall. So no matter what system you're on, so we're representing all, three of the major players here, there's different places that logic lives. If when you make changes to the way you charge or the codes that come out, did you look thoroughly at all these different places to make sure that that's going to happen the way you intend it to? So what Eric was mentioning before, it's point of care to claim. Did it work as intended? When I make a change, did I think I started charging for something, but it actually never made it to the claim? Because there's some logic that was in there that you didn't know about, that maybe never fired because that charge didn't exist before. But now that it's firing, it's just taking it off because it's not supposed to be there, or it wasn't supposed to be there in the past. So just a different way. It can also be very beneficial. So I myself am not a proponent of back-end logic unless it's a stopgap measure. You should be fixing things at the point of care, working with your clinicians, leveraging what they already document to drive your charges. It's documented, it's supported, it's charged. It's a perfect example of what should happen. Back-end logic, there's people that are not as close to the service. They don't understand it. They may choose something that isn't actually representing what should be charged. So there's 1,000 places that it's great to create logic, but you just need to make sure that you're using it effectively and that you've gone all the way downstream and made sure that it's working as intended. So overall, we talked a little bit about kind of that work plan. You got all these priorities on the slide that you couldn't see half the bubbles. Prioritization of the things that you need to do, making sure that you involve the right people, making sure that you understand what current state is so that you truly understand the impact of what you're changing it to. so that you know what to look for when you report on what you've just changed. Because everything that you guys change, you want to make sure you're monitoring. Did it have the impact and the intended outcome that I thought it would or that we think it should? Because there's a lot of things that play into that, whether it's education or the system isn't working as anticipated. So fully understanding what current state is, why it's broken, how you design how to fix it, and then how you monitor, did that fix happen and hold? Is it sustainable? So, and then just prioritizing those things so that you're not boiling the ocean, but you're able to tackle opportunities. And that's just a little bit more about that. So making sure that you have the right team members and leadership supporting the changes that you're putting in place. Work groups are very effective. It's an everyday thing of what we do in our project work because you bring the right people to the table. A lot of times organizations think, okay, a leader of a clinical area is going to make that decision. But who's actually doing the work? The clinical folks. If they don't know about it, aren't trained, don't have a stake at the game, they don't feel like they have buy-in, it's not going to be successful. So you need to make sure you have the right people and roll it out appropriately for it to be successful. Is it time for you guys to review some of your charges? Are these some things that are happening? There's no margin. You're hearing from the top that, you need dollars. Where is it at? Nobody wants to say, hey, let's do a layoff, right? Why not go out and find revenue that already should exist because you have services you are providing, you're just not charging for them. So that's why it's my favorite part of the mid-cycle. And then just, different things that can go awry, like I already talked about if you do system upgrades or things like that, mergers or acquisitions where you're trying to bring two people together and things are different, whether that's workflows or even the charge structures, that's where things can go awry. All right. This is just an example while I have you guys as my captive audience. An organization, a large academic medical center, just wanted us to take a look at their charges. So we were able to bring them additional recurring $12 million in annual net revenue. So instead of laying off people to meet budget, they were able to find charges for services they were already providing. So it's a positive way to meet budget, to hit those financial targets. So. But it requires the right infrastructure. It requires you knowing about your automation, having some reconciliation processes, a process to really find those opportunities, because if they were easy to find, they wouldn't be opportunities. So I know that everybody really wants to get out of here. So I'm going to leave it to questions, which I've been asking for a whole time. But if
anybody that needs to take off, we won't be offended. But if you want to ask a question or stick around and hear other people's, we'll be here for a few more.
Thanks you both. That was a great presentation. I have a very specific question that I'm hoping to get your input on or feedback from the audience. But you're right. We're all responsible for revenue cycle in our organizations, and you're right that we're always trying to find out where are we missing revenue opportunity. We're looking at pre-op and post-op visits right now, and I'm interested to know if organizations are billing the facility fee for a pre-op or a post-op visit by the hospital. And the reason that it's an interesting question to me is because we have outpatient provider-based clinics where if the patient is commercially insured, we're billing it globally, place of service 11, through professional billing only. It's not eligible for a facility fee. But if we have a patient who has Medicare coverage, for example, in a clinic, you're billing the professional component separate from the facility claim. And you're technically eligible to bill that facility charge for that visit. But to your point, when you were kind of summarizing everything, charge for what you can charge for, but in this instance, you can only charge if it's a facility claim that's going out, and now you're not treating patients fairly if some get it and some don't. So I'd love to know what you would recommend in that situation, and I'd be interested to know if other organizations have chosen intentionally whether or not to bill that facility code for pre-op and post-op visits.
Yeah. I think it's complicated, so I'll try, and we can follow up too. But rule of thumb that I would say is that if they came in to your facility and were provided care, the point of a facility charge is to cover the resources to take care of that patient. So it's a service that you provided that you bill for. And you don't just bill one payer, you bill all payers. So there may be some nuances to how, there is very complicated logic when it comes to PBB and the whole deal. But the way in which those charges should be set up is that even though you're billing a global, that global should equal what your professional and your facility is. So if you're splitting it for one payer, the price of that service should still be the same when you're billing it, when it's together. So, but you're billing it, right? So you should be billing it consistently. Right.
Because it's pre-op and post-op and it's not separately payable, it's $0 at our organization. So that's.
Yeah. And again, it's that separately payable versus separately billable conundrum. Yeah.
Hi, great presentation, thank you. So my question has to do with determining where the charge capture should happen, and when to centralize certain pieces of it, or because I think it's an interesting question from a FTE efficiency perspective. You could live with operations, right, versus centralizing it. You could kind of maybe have a hybrid model where you've got dedicated resources within specific operational departments like procedural areas. But then the rest of charge capture lives with, the HUC and the management team, whatever. So what's kind of how would you approach that and thought process?
It's a great question. And the politically correct answer is going to vary by organization, right? But what I would say, in all honesty, is that at the point of care is the best place to capture a charge. So you want to evaluate if your system can allow you to do that through the documentation that's already happening. No additional resources, right? I'm a clinician. I'm a respiratory therapist, and I'm documenting peaks and flows. Something in my flow chart can be used to trigger a charge. I'm not going to a separate place. I'm not taking any additional time to charge for something. So evaluating what your system can do and what the services are being provided. There's always going to be an instance where you have to intervene manually. The best example I can give, which is a pain point for every organization I work with, infusion services, right? The hierarchy, logic, I think this was a wild, wicked game that CMS decided to play with us, right? So it's just so difficult. There has to be a component of review. Epic says it can do it, but it doesn't do it well. So, there's areas where you have to have a manual component. So whether that's centralized or not, I think it comes down to each organization's resources, who they have available. So I know that's not the answer you want to hear, but I think there are ways to evaluate that appropriately. Yeah. Great question.
Anyone else?